Hello everyone and welcome back to NCLEX Made Easy 91. Today we're diving into essential NCLEX pharmacology questions focused on midwifery and gynecology. These NCLEX style questions come with detailed rationales to help you not only select the right answers, but truly understand the reasoning behind them. This session is carefully designed to enhance your test-taking strategies, deepen your knowledge, and boost your confidence as you prepare for exam success. So get your notes ready, settle in, and let's jump straight into these high-yield practice questions. Question 1. A pregnant woman at 36 weeks is prescribed magnesium sulfate for severe preeclampsia. Which finding indicates magnesium toxicity? A. Increased deep tendon reflexes. B. Urine output of 50 ml per hour. C. Respiratory rate of 10 breaths per minute. D. Blood pressure 140/90 mmHg. Correct answer is C. Respiratory rate of 10 breaths per minute. Rationale: magnesium sulfate depresses the central nervous system and may lead to respiratory depression less than 12 per minute. Loss of deep tendon reflexes and oliguria are also signs of toxicity, but respiratory depression is the most life-threatening. Strategy: focus on safety and ABCs. Airway, breathing, circulation. The most critical assessment in drug toxicity questions is the finding that threatens life first. Question 2. A postpartum client is prescribed methyl-ergovine methergin. Which condition is a contraindication to this medication? A. Hypotension. B. Hypertension. C. Bradycardia. D. Hypovolemia. Correct answer is B. Hypertension. Methergin is an ergot alkaloid that increases uterine tone but can cause dangerous vasoconstriction and hypertension. It's contraindicated in clients with high blood pressure. Strategy: always match drug adverse effects with contraindications. Methergin, vasoconstriction, don't give if hypertensive. Question 3. A client at 40 weeks in active labor is receiving oxytocin or pitocin infusion. The nurse notes contractions occurring every 1 minute lasting 90 seconds. What should the nurse do first? A. Stop the infusion immediately. B. Decrease the infusion rate by half. C. Reposition the client to her left side. D. Administer oxygen via nasal cannula. Correct answer is A. Stop the infusion immediately. Contractions that are too frequent or long, tachysystole, can cause fetal hypoxia and uterine rupture. The first priority is to stop oxytocin. Repositioning and oxygen may follow. Strategy for oxytocin: think uterine hyperstimulation. Stop infusion first, before any other interventions. Question 4. The nurse is caring for a postpartum woman prescribed carboprostin hemabate for uterine atony. Which condition must the nurse assess before administration? A. Asthma. B. Diabetes. C. Hypothyroidism. D. Cardiac arrhythmia. Correct answer: A. Asthma. Carboprostin is a prostaglandin that may cause bronchospasm, which is contraindicated in asthma patients, so always connect drug adverse effects with pre-existing conditions. Carboprostin, bronchospasm, check for asthma. Question 5. A pregnant client with preterm labor is prescribed terbutaline breathing. Which adverse effect is most concerning? A. Palpitations. B. Tremors. C. Hypotension. D. Tachycardia greater than 140 BPM. Correct answer is D. Tachycardia 140 BPM. Terbutaline, a beta-adrenergic agonist, may cause maternal tachycardia. Severe tachycardia greater than 140 BPM indicates toxicity and requires immediate intervention. Strategy: when evaluating side effects, select the most dangerous or life-threatening rather than the expected mild ones. Question 6. A nurse administers rhodiimmune globulin, RHOGAM, to a postpartum client. Which laboratory finding indicates the need for this medication? A. Newborn is Rh positive, mother is Rh negative. B. Both mother and newborn are Rh negative. C. Mother is Rh positive, newborn is Rh negative. D. Both mother and newborn are Rh positive. Correct answer is A. Newborn is Rh positive, mother is Rh negative. RHOGAM prevents maternal antibody formation against Rh positive blood, only required if the mother is Rh negative and the baby is Rh positive. Strategy: Always match the drug purpose to the clinical scenario. RHOGAM, RH incompatibility. Question 7. A nurse is preparing to administer dinoprostone, Cervidil, for cervical ripening. Which assessment is most important before giving this medication? A. Baseline fetal heart rate. B. Hemoglobin level. C. Amniotic fluid color. D. Presence of hemorrhoids. Correct answer is A. Baseline fetal heart rate. Dinoprostone or prostaglandin can cause uterine hyperstimulation leading to fetal distress. Baseline fetal monitoring is essential before administration. Strategy: when drugs affect uterine contractions, always assess fetal well-being first. Question 8. A nurse is caring for a woman prescribed oral contraceptives. Which symptoms should be reported immediately? A. Nausea. B. Headache with visual disturbances. C. Breast tenderness. D. Mild weight gain. Correct answer is B. Headache with visual disturbances. This may indicate thromboembolic events, stroke, clot formation, a serious adverse effect of estrogen-containing contraceptives. So use the ACIS acronym for contraceptive danger signs: abdominal pain, chest pain, headaches, eye problems, severe leg pain. Question 9. A nurse prepares to administer clomiphene citrate to a woman being treated for infertility. The nurse should explain that the most common side effect is A. Visual disturbances, B. Hot flashes, C. Weight loss, D. Hair loss. Correct answer is B. Hot flashes. Clomiphene stimulates ovulation and commonly causes hot flashes due to estrogen modulation. Visual disturbances are less common but more serious. Strategy for infertility drugs: always distinguish between common side effects, which are expected, versus serious adverse effects, which are reportable. Question 10. A nurse is administering misoprostol cytotec for induction of labor. Which client statement requires immediate intervention? A. I am having contractions every 2 minutes. B. I feel my baby moving less than before. C. I feel slight cramping after the dose. D. I had a bowel movement after the medication. Correct answer is B. I feel my baby moving less than before. Decreased fetal movement indicates possible fetal distress, which can occur due to uterine hyperstimulation from misoprostol. So always prioritize fetal well-being in labor induction questions.
Question 11. A client with preterm labor at 30 weeks is started on nifedipine. Which vital sign warns holding the next dose? A. Pulse 92 per minute. B. Blood pressure 86 over 54 millimeters of mercury. C. Respiratory rate 18 per minute. D. Temperature 37.5 degrees Celsius, 99.5 degrees Fahrenheit. Correct answer: B. Blood pressure 86 over 54 millimeters of mercury. Rationale: nifedipine, a calcium channel blocker, can cause hypotension. Hold if BP is low to prevent maternal hypoperfusion. Strategy: link drug class to expected effects. CCBs to vasodilation, so hypotension is the red flag. Question 12. A pregnant client at 28 weeks receives betamethasone. What is the primary therapeutic goal? A. Prevent uterine contractions. B. Enhance fetal lung maturity. C. Increase maternal blood pressure. D. Treat maternal infection. Correct answer: B. Enhance fetal lung maturity. Rationale: antenatal corticosteroids accelerate fetal surfactant production and reduce neonatal RDS. Strategy: match medication to neonatal outcome for preterm risk questions. Question 13. A 10-week pregnant client has nausea and vomiting unrelieved by diet. The safest first-line drug is A. Ondansetron. B. Doxylamine pyridoxine. C. Metoclopramide. D. Promethazine. Correct answer: B. Doxylamine pyridoxine. Rationale: combination vitamin B6 with antihistamine is first line for NVP in early pregnancy. Strategy: prioritize established first-line pregnancy safe options. Question 14. A woman with GBS colonization in labor has a penicillin allergy with anaphylaxis history. Which intrapartum antibiotic is appropriate after susceptibility testing shows sensitivity? A. Ampicillin. B. Clindamycin. C. Cefazolin. D. Vancomycin. Correct answer: B. Clindamycin. Rationale: for severe penicillin allergy, Clindamycin is used if the isolate is susceptible, otherwise vancomycin. Strategy. Use allergy plus susceptibility to choose targeted therapy. Question 15. A client at 39 weeks on oxytocin shows late decelerations on FHR. What is the nurse's first action? A. Increase IV fluids. B. Stop oxytocin infusion. C. Notify the provider. D. Apply internal scalp electrode. Correct answer. B. Stop oxytocin infusion. Rationale. Late decelerations indicate uteroplacental insufficiency. Stopping oxytocin reduces uterine stress. Strategy. For fetal distress with uterotonic infusions, stop the cause first. Question 16. A postpartum client with heavy bleeding received oxytocin without control of hemorrhage. The provider orders tranexamic acid. What key assessment is priority before administration? A. Visual acuity. B. History of thromboembolism. C. Deep tendon reflexes. D. Bowel sounds. Correct answer. B. History of thromboembolism. Rationale. TXA is an antifibrinolytic and increases clot risk. Assess VTE history. Strategy. Scan for contraindications related to clotting with hemostatic drugs. Question 17. A postpartum client with at-knee is ordered carboprost. The nurse should question the order if the client has a history of A. Migraines. B. Asthma. C. GERD. D. Hypothyroidism. Correct answer. B. Asthma. Rationale. Carboprost can cause bronchospasm, contraindicated in asthma. Strategy. Tie adverse effect to pre-existing disease. Question 18. A Rh-negative mother delivered an Rh-positive infant. Rh-OD immune globulin is most effective when given within A. 12 hours postpartum. B. 24 hours postpartum. C. 48 hours postpartum. D. 72 hours postpartum. Correct answer. D. 72 hours postpartum. Rationale. Administer within 72 hours to prevent Rh sensitization. Strategy. Memorize timing windows for preventative pharmacotherapy. Question 19. A client with hyperthyroidism in the first trimester requires medication. The safest initial choice is A. Methimazole. B. Propylthiouracil, PTU. C. Radioactive iodine. D. Levothyroxine. Correct answer. B. Propylthiouracil, PTU. Rationale. Propylthiouracil is preferred in first trimester. Methimazole is preferred in second and third due to PTU hepatotoxicity. Strategy. Note trimester-specific drug preferences.
Question 20. A 34-year-old smoker, 1 pack per day, requests combined oral contraceptives. Best nursing action is to A. Initiate COCs with close monitoring. B. Recommend progestin-only methods. C. Suggest adding aspirin for clot prevention. D. Start COCs but avoid high estrogen pills. Correct answer. B. Recommend progestin-only methods. Rationale. COCs are contraindicated in smokers greater than 35 due to thrombotic/stroke risk. Choose POPs, IUDs, or implants. Strategy. Apply absolute contraindications for estrogen. Question 21. A client on depot medroxyprogesterone acetate, DMPA, asks about adverse effects. Which is most important to discuss? A. Weight loss. B. Bone mineral density loss. C. Hypertension. D. Frequent menses. Correct answer. B. Bone mineral density loss. Rationale. Long-term DMPA can reduce BMD, encourage calcium, vitamin D, weight-bearing exercise. Strategy. Prioritize long-term safety counseling. Question 22. A copper IUD is being placed. Which finding is a contraindication to insertion today? A. Irregular menses. B. Positive pregnancy test. C. Nulliparity. D. Mild dysmenorrhea. Correct answer. B. Positive pregnancy test. Rationale. Pregnancy is a contraindication to IUD insertion. Strategy. Eliminate distractors by recalling absolute no-go conditions. Question 23. A client treated for ectopic pregnancy receives methotrexate. Which instruction is essential? A. Take folic acid daily. B. Avoid alcohol and NSAIDs. C. Increase high-protein diet. D. use heating pads for pain. Correct answer. B. Avoid alcohol and NSAIDs. Rationale. Methotrexate is hepatotoxic and nephrotoxic. Alcohol and NSAIDs increase toxicity. Avoid folic acid supplements, which reduce efficacy. Strategy. No drug-substance interactions that increase toxicity. Question 24. A pregnant client at 20 weeks has asymptomatic bacteriuria. The preferred treatment is A. Ciprofloxacin, B. Doxycycline, C. Nitrofurantoin, avoid at term, D. Trimethoprim sulfamethoxazole in third trimester. Correct answer. C. Nitrofurantoin, avoid at term. Rationale. Nitrofurantoin is commonly used mid-pregnancy. Avoid near term due to risk of hemolysis in G6PD deficient neonates. Strategy. Choose pregnancy-safe antibiotics with gestational caveats. Question 25. A pregnant client with chlamydia needs treatment. Best option is A. Doxycycline, B. Azithromycin single dose, C. Ciprofloxacin, D. Levofloxacin. Correct answer. B. Azithromycin single dose. Rationale. Azithromycin is safe and effective in pregnancy. Doxycycline is contraindicated. Strategy. Match infection to pregnancy-safe agent. Question 26. A pregnant client at 33 weeks with preterm labor is started on indomethacin. Which condition limits its use? A. Maternal anemia, B. Gestational age beyond 32 weeks, C. Maternal obesity, D. GDM diet controlled. Correct answer. B. Gestational age beyond 32 weeks. Rationale. Indomethacin after 32 weeks risks premature ductus arteriosus, closure, and oligahydranose. Strategy. Tie drug fetal effect to gestational cutoff. Question 27. A client needs emergency contraception within 72 hours of unprotected sex, is breastfeeding, and not on medications. Best choice is A. Ulipristal acetate, B. Levonorgestrel 1.5 milligrams once, C. Mifepristone 200 milligrams, D. Copper IUD within 14 days. Correct answer. B. Levonorgestrel 1.5 milligrams once. Rationale. Levonorgestrel is OTC, effective up to 72 hours, and compatible with breastfeeding. Strategy. Consider timing plus lactation safety. Question 28. A pregnant client asks about vaccines. Which is contraindicated during pregnancy? A. Tdap at 27 to 36 weeks. B. Inactivated influenza. C. MMR. D. Hepatitis B. Correct answer, C. MMR. Rationale. Live vaccines, MMR, varicella, are contraindicated in pregnancy. Strategy. Separate live versus inactivated vaccines. Question 29. A client with bacterial vaginosis in the second trimester should receive A. Metronidazole, B. Doxycycline, C. Fluconazole oral, D. Clindamycin vaginal only. Correct answer. A. Metronidazole. Rationale. Metronidazole is effective and safe after the first trimester for BV. Strategy. Recall standard first-line regimens by condition. Question 30. A breastfeeding client with mastitis needs antibiotics. Appropriate first-line option is A. Amoxicillin clavulanate, B. Dicloxacillin, C. Doxycycline, D. Ciprofloxacin. Correct answer. B. Dicloxacillin. Rationale. Dicloxacillin or cephalexin covers typical MSSA and is safe in lactation. Strategy. Choose narrow, safe coverage when possible.
Question 31. A client on SSRIs for postpartum depression is breastfeeding. Which counseling point is most accurate? A. SSRIs are absolutely contraindicated. B. Continue SSRI, monitor infant for irritability or poor feeding. C. Stop breastfeeding while on SSRIs. D. Switch to benzodiazepines for safety. Correct answer, B.
Continue SSRI, monitor infant for irritability or poor feeding. Rationale: many SSRIs are compatible with breastfeeding. Monitoring is prudent. Strategy: balance maternal mental health with lactation safety. Question 32. A client with postpartum endometritis requires IV antibiotics. The standard combination is A. Ampicillin plus sulbactam, B. Clindamycin plus gentamicin, C. Piperacillin tazobactam alone, D. Vancomycin alone. Correct answer, B. Clindamycin plus gentamicin. Broad anaerobic and gram-negative coverage is achieved with Clinda plus gent. Strategy: no classic combination regimens for obstetric infections. Question 33. A pregnant woman with HIV is prescribed zidovudine during labor. The primary goal is to A. Treat maternal infection, B. Prevent neonatal sepsis, C. Reduce vertical transmission, D. Improve maternal CD4 count acutely. Correct answer, C. Reduce vertical transmission. Rationale: intrapartum zidovudine reduces risk of mother-to-child HIV transmission. Strategy: identify peripartum prophylaxis objectives. Question 34. A pregnant client at 10 weeks asks about folic acid. Recommended daily dose for average risk clients is A. 200 micrograms, B. 400 to 800 micrograms, C. 1 milligram, D. 4 milligrams for all clients. Correct answer, B. 400 to 800 micrograms. Rationale: standard prevention of neural tube defects is 0.4 to 0.8 milligrams daily, 4 milligrams for high-risk histories. Strategy: memorize preventative micronutrient doses. 36. A 38-week pregnant client takes ibuprofen for back pain daily. The nurse's priority teaching is that third trimester NSAIDs may cause A. maternal hyperglycemia, B. fetal ductus arteriosus closure, C. maternal hypertension, D. placental abruption. Correct answer, B. fetal ductus arteriosus closure. Rationale: late pregnancy NSAIDs can constrict the ductus and reduce fetal renal perfusion. Strategy: connect drug prostaglandin effects to fetal circulation. A patient with PCOS desires pregnancy and is starting metformin. The expected metabolic benefit is A. increased estrogen synthesis, B. improved insulin sensitivity and ovulation, C. suppression of LH surge, D. direct stimulation of FSH receptors. Correct answer, B. improved insulin sensitivity and ovulation. Rationale: metformin reduces insulin resistance, which can restore ovulation in PCOS. Strategy: link mechanism to clinical fertility outcome. Question 39. A client starting clomiphene should be counseled that a notable risk is A. ovarian hyperstimulation syndrome with ascites in most users, B. multiple gestation, C. severe hypothyroidism, D. chronic hypertension. Correct answer, B. multiple gestation. Rationale: ovulation induction increases the risk of twins. Strategy: distinguish common testable risks from rarer complications. Question 40. A postpartum patient requires analgesia while breastfeeding. Best first-line option is A. codeine, B. oxycodone, C. ibuprofen, D. meperidine. Correct answer, C. ibuprofen. Rationale: ibuprofen is compatible with breastfeeding. Avoid codeine due to variable metabolism and infant toxicity risk. Strategy: prefer non-opioids, safe in lactation.
Question 41. A client with trichomoniasis who is breastfeeding asks about therapy. Best recommendation is A. Metronidazole single dose and temporarily hold breastfeeding for 12 to 24 hours if advised. B. Doxycycline for 7 days. C. Fluconazole 150 milligrams once. D. Clotrimazole cream alone. Correct answer is A. Metronidazole single dose and temporarily hold breastfeeding for 12 to 24 hours if advised. Rationale: metronidazole treats trichomoniasis. Some guidelines advise brief pump and discard after high single doses. Strategy: match standard of care while noting lactation precautions. Question 42. A client with GDM needs pharmacologic therapy. The first-line medication is typically A. Insulin, B. Glyburide, C. Metformin only, D. Acarbose. Correct answer is A. Insulin. Rationale: insulin is preferred when diet and exercise fail. Oral agents may be used in some settings, but cross-placenta to varying degrees. Strategy: for diabetes in pregnancy, insulin is safest standard. Question 43. A client on misoprostol for cervical ripening develops tachysystole. Which antidote or agent may be considered to relax the uterus if supportive measures fail? A. Naloxone, B. Terbutaline, C. Protamine sulfate, D. Flumazenil. Correct answer is B. Terbutaline. Rationale: terbutaline is a beta agonist, reduces uterine activity. Strategy: no physiologic opposites to counter adverse effects. Question 44. A client with endometriosis is prescribed leuprolide. Which adverse effect is expected without add-back therapy? A. Hyperestrogenism, B. Bone density loss and hot flashes, C. Hyperprolactinemia, D. Severe hypertension. Correct answer is B. Bone density loss and hot flashes. Rationale: GnRH agonists cause hypoestrogenism, leading to vasomotor symptoms and BMD loss. Strategy: link mechanism to downregulation effects to estrogen deficiency. Question 45. A 24-year-old using progestin-only pills asks what to do if a pill is taken more than 3 hours late. Best advice is to A. Take 2 pills next day and no backup needed. B. Take missed pill immediately and use backup for 48 hours. C. Skip the missed pill and continue as scheduled. D. Stop and restart next cycle. Correct answer is B. Take missed pill immediately and use backup for 48 hours. Rationale: POPs have a short window. Backup contraception is needed if more than 3 hours late. Strategy: memorize time-sensitive rules for POPs. Question 46. A client with hyperemesis gravidarum unresponsive to doxylamine pyridoxine receives ondansetron. Which adverse effects should be monitored closely? A. QT prolongation, B. Hyperkalemia, C. Hyponatremia, D. Hypoglycemia. Correct answer is A. QT prolongation. Rationale: ondansetron may prolong QT, especially with electrolyte abnormalities. Strategy: watch for cardiac conduction issues with antiemetics. Question 47. A client at 12 weeks with vulvovaginal candidiasis needs treatment. Preferred therapy is A. Oral fluconazole 150 milligrams once. B. Topical azole therapy for 7 days. C. Nystatin oral suspension. D. Clotrimazole oral tablets. Correct answer is B. Topical azole therapy for 7 days. Rationale: topical azoles are preferred in pregnancy. Oral fluconazole is generally avoided. Strategy: choose topical over systemic in early pregnancy when effective. Question 48. A client with severe preeclampsia is on magnesium sulfate. Which medication should be available for antidote use if toxicity occurs?
A. Calcium gluconate, B. Vitamin K, C. Protamine sulfate, D. Atropine. Correct answer is A. Calcium gluconate. Rationale: calcium antagonizes magnesium's effects and reverses respiratory and cardiac depression. Strategy: pair toxicity to specific antidote. Question 49. A client asks about ulipristal acetate for emergency contraception 5 days after unprotected intercourse. Appropriate counseling is A. It is ineffective after 72 hours. B. It can be used up to 120 hours and requires a prescription. C. It must be taken with food to work. D. It is less effective than levonorgestrel at any time. Correct answer is B. It can be used up to 120 hours and generally more effective than levonorgestrel late in the window. Strategy: match time window with the best agent. Question 50. A postpartum client with heavy bleeding did not respond to oxytocin and has BP 170 over 92 millimeters of mercury. Which uterine tonic is contraindicated now? A. Misoprostol, B. Carboprost, C. Methyrgonevin, D. Tranexamic acid. Correct answer is C. Methyrgonevin. Rationale: methergin can severely raise BP and is contraindicated in hypertension. Strategy: always screen vitals-based contraindications before giving uterine tonics. Thanks for watching NCLEX Made Easy 91, where we make nursing